So I will continue as industrial symposium by the known artists, and there will be excellent talk. Today we will explore the latest advancement in the diabetes management, focusing on the time in range in the real world settings. To explore the limitation of the A1c matrix and discover the significance of the time in range in diabetes management, this presentation leads into the real world evidence from the ARRIVE study and highlighting the rhizodec effectiveness initiations and switching scenarios. For this, first of all, I would like to call the chairpersons to chair these sessions. So, first I will call the Dr. Fawad Randhawa, and he's Associate Professor of Endocrinology, currently working in the King Edward Medical University. Sir, please take your seat on the Dr. Fawad Randhawa. So, I will call the Professor Bilal bin Yusuf. Please, sir, come on the stage to take the chair. So, to absence of these persons, I will request the Professor Umar Yusuf Raza to please chair the seat. And Professor Khushi Raman Khan, sir, please, sir. Thank you so much. So, to understand this latest advancement, I would like to call our first speaker is Professor Aamir. He is Professor of Medicine and Endocrine at our Medical Complex, Peshawar. Sir, please.
Assalamu alaikum. Thank you very much, and good afternoon. And thank you for everybody to be here at this time of the day, and I believe I'll be optimistic. It's probably for my talk, but I think realistically it's the debate which they are waiting for. Thank you for organizers for giving the opportunity for this talk. Right. These are my disclosures. We have got lots of problems when you talk about diabetes, because managing diabetes effectively is close to it's a task which is really not able to achieve for various reasons. And some of the reasons are written here. You can see the load that we have, the time that we can give to our patients, the support that we require for managing diabetes in the outpatients. And also, one of the major problems is, despite if you have all these things, despite all that, you will have issues related to diabetes in terms of complications that the patient will get. And that sometimes frustrates us. But one of the better things over the time that we have got is the newer technologies that we have. And you must have seen this in Ahmed's presentations, these diabetes management and the recordings, the CGMs, the pumps that we are using these days so oftenly. So technologies have helped us to manage diabetes better. But one of the things which still stands out is the A1c. A1c, if you look at the history, it's been over 1966 and 68 and 63. But I think DCCT establishes in 1993 the value of A1c. That's where it started. And it continued, and if you look at any trial, any outcome studies, it's the A1c that we are looking at, the outcome studies. But I think after a decade from the advent of A1c for type 2 diabetes and the outcome studies, there came a time when it was realized that despite the A1c being used as a metrics, people are still having problems. And that's where the CGM came in, and then the international consensus on standardization of glucose repositing metrics and the CGM came in 2017 and 19. So I think 2019 was a time when the recommendations actually put CGM as a part of the management. So there was an A1c era, we know that, because that was one of the metrics what we were looking at for diabetes care and for the efficacy of drugs as well. And also this was a standard marker, and so much so that the ADA and many other organizations, IDF and all that, they made A1c as a diagnostic criteria. So we used to have a fasting, we used to have a postprandial, we used to have a oral glucose tolerance, but they were all considered whether they are reproducible or not. So A1c was becoming so important that that became a marker for diagnostic criteria as well. And the targets to use A1c was to modify therapy or to set up a therapy was used. And also, if you look at from regulatory point of view, the safety and efficacy of newer drugs was marked based on A1c. So this was the era, and we've been through this all the time. But there are some problems with A1c, and one of the major problems with that is that it may not be optimal. It doesn't identify hypoglycemia or glucose variability, that I'll be touching, and it can be affected with a wide range of physiological and pathological conditions. And there may be lots of glucose profile, and I'll show you later in my presentations that though your A1c may be pretty decent, but the profiles may not reflect that. So look at this list. Plenty of issues related to falsely high or falsely low A1c, yet we are using it. And particularly from our set of patients and our point, particularly in the north where thalassemia traits is quite common, I think this is one of the issues which you need to consider amongst many other issues related to A1c. So there are limitations. Yes, it cannot be used as a single guide, and that's why the recommendations have shown that we used to do different metrics, which was CGM, which has been incorporated. It does not, A1c does not identify hypoglycemia and glucose variability, and it's very common statement. They say your head is in the freezer and tail is in the fire. Your average may be good, but you will not be feeling good. So I think that's where the problem is with the A1c sometimes. It can be affected by a wide range of conditions, as I mentioned, and wide range of profile can be associated with A1c. So if you look closely, there are 3 A1cs here, and there's example 1. Look at the numbers, 58%, around 180 and thereabout. And if you compare it to example 3, both A1cs are similar. And that's where the concept of time in range comes, that your A1c may be same, but your time in range may not be the same in all the situations. And it's the quality of A1c can be very different when you're looking at it. So we have moved from A1c to time in range, because time in range goes beyond A1c in representing the blood glucose, because it captures the variations of highs and lows, and in range that is characterized diabetics. So this is a typical what we've seen in ATTD, which shows that the variation that you have, and different countries move from different rates in regards to implementing these changes. So it's the range, that's a percentage of time a patient is within the glycemic range of 70 to 180. This is TIR, this is time in range, that's his definition. The evidence suggests that the time in range is inversely correlated, as is the A1c, but it is inversely related to the risk of developing vascular complications in patients with diabetes. Time in range may be used as appropriate clinical endpoint in diabetes research, and going beyond time in range can lead to hyperglycemia and hypoglycemia. So if you look at the targets, and those of you who were in the workshop done by Dr. Qamar Masood, he has shown elegantly in that workshop, I was sitting there, that the time in range you need to be for type 1 and type 2 is around 70%. So this is your time in range between 70 180. And this is time below range, which is less than 1% you need to be. And then time above range. And then there are two shades of that, which is more than 180 and more than 250. So for CGM-based targets of different diabetes population, this is what we are targeting. This is what we are shooting for, 70% or above. Each incremental 5% increase in time in range is associated with clinically significant benefits for both in type 1 and type 2 diabetes. For pregnancy and type 1 diabetes and pregnancy and GDM and type 2 diabetes, again, we have got range for type 1, which is 70%, but for pregnancy and GDM, it is much higher. And the important point is every 5% increase in time in range will have outcomes which may be beneficial for a patient. And similarly, it may be reducing the complication range as and when required. And this is what it shows. If you look at retinopathy and microalbuminuria, for each 10% less time in range, retinopathy progression is increased by 64% and microalbuminuria by 40% for each combination. So you're starting from 70% time in range, going above, you can see the inverse correlation that lower the time in range, the more the chances of developing complications patients would have. So comparing the both, A1c is a single value. It compares every 3 months. Variability is not recorded. Immediate effects are not recorded. And there's a high susceptibility for interference with various issues related to anemia and different labs and standardization. But if you look at time in range, it's a continuous glucose level, compares any time periods, reflects glucose excursions, and low susceptibility of interference with different. So we know that it is expensive tool to be used to detect time in range using the CGM. So there's a concept of called derived time in range and role of degludec that I'll be talking a little later. What is derived time in range? Now, this was seen in this study, and the method of calculation is that if you have a 9-point self-monitoring blood glucose profiles taken in a weeks at different times, so the time of points of finger readings are before the breakfast, lunch, and dinner, as you have a pre-meal, 90 minutes after each meal, bedtime, 4 a.m., and before the breakfast for the next day. So if you have number of range, and you need to have minimum of 6 of these, and if you put this readings and divide it by number of total recordings and multiply by 100, you'll get derived time in range. And that will give you closely the idea of what your patient. So regardless of whether you can use a CGM or not, you can have a derived time in range calculation by this method. So this was a Boost Japan study. It was a patients with type 2 diabetes previously treated with 1 OAD at least 12 weeks and recommended dose. A1c was, as with many trials, is 7 to 10%, BMI 35, age 20, and they were randomized to include insulin IDegAsp versus insulin glargine along with metformin, and they wanted to confirm the non-inferiority of the IDeg combination compared to insulin glargine. So if you look at a time in range, they were slightly better with an insulin IDeg if you compare the both, and that's again a derived time in range. But the other study I would like to mention here is the ARISE study, which was done in type 2 diabetic patient, and insulin IDeg was used as per local practice. It was non-interventional, multi-center prospective study, and it was done in countries which are mentioned on the left side. But the key inclusion criteria was physician decision. It was a real-world study. Physician decision to initiate the treatment. What was the reasons that they wanted to initiate insulin IDegAsp? Age was more than 18 years, diagnosed with type 2, treated with any anti-hyperglycemic medication other than insulin IDegAsp, and the available A1c values of less than 12 weeks. There were patient invited was 1,400, quite a big number. 1,100 signed the consent, and 1,102 exactly initiated on IDegAsp, and patient who completed was 1,015. Important point to note is people who, the researchers who do studies, it is very common to see the dropouts. It is very common when you're changing the treatment for one patient or the other, they would not continue the study for one reason or the other. But look at the percentage of patients who completed the studies, 92%, which was a big number. So previous anti-hyperglycemic medication, OADs, as one would imagine, that a lot of patients who are on OADs, there were patients who were on basal only, there were patients who were on GLP receptor agonists, basal and bolus regime and premixes. And overall, the major reason to start a treatment of IDegAsp was that patient, despite on those many treatments, were not controlled. So that was a major determinant in almost all the patients, but then to lower the risk of hypoglycemia for one reason or the other, flexibility. There were patients who were on basal bolus, and obviously patient doesn't want to be on a basal bolus. And if you're on basal bolus and despite that you are not achieving the target, you need to think it. So this was all real world data at the discretion of treating physicians, and there were other reasons as well. So what were the results? If you look at overall, there was improvement in A1c of minus 1.4%. This is the real world data. But what I looked very closely was patients who were on OADs, and I think this applies to us, to our population. If you look at people who are on patients with diabetes who are only on OADs, responded very well. And I think the basic logic behind is that we are continuing OADs for a longer duration of time. So I think we are introducing insulin quite late in the management, and this is across the countries which I've just mentioned. And I think same is probably the case for Pakistan as well. And if you look, in all these set of patients, the A1c improved. What was important to note was that there was slight change in the weight as well, except, of course, the GLP, because GLP itself reduces the weight. So if you're switching from GLP to IDegAsp, the chances that you will gain weight was seen in GLP. But in all the others, there was drop in weight. One would argue that you are putting a patient on insulin and yet you are getting weight loss, which is not physiological, but I think one of the reasons which could be that the protective mechanism for patients who are on insulin or who are on drugs which cause hypoglycemia is a protective way of eating more than what they used to. And if they are controlled a bit better, probably they will not use the more eating related to prevent hypoglycemia. The clinical interpretation of ARISE study showed that there was a real-world reduction in A1c around 1.4%. There was a weight loss of up to 1 kilo, except in the category where GLP was switched, and there was low nocturnal hypoglycemia rates and no increase in healthcare resource utilization. Because imagine if a person with a hypoglycemia comes to hospital and requires treatment in the hospital, the resources mobilized are huge, and I think that cost we need to look into. In the renal function, IDEC insulin has got not much, it's quite neutral, and you need to be wary of using the titrating dose in your patients. So intensifying monitoring and individualizing insulin use in those patients is important, and that would be left on the discretion of a treating physician, but you've got to be careful. I'll quickly mention one, I've got 1 minute left. This is a real case, and we got a special permission to put this real case. A 22-year-old male, type 1 diabetes, on basal bolus, 7.7, which by Pakistani standards could be pretty good, you know, but you're starting off pretty at low level, 7.7, but because it's young patients, you would like to improve. And on, as one would imagine, it is on basal bolus, but morning self-monitoring shows more than 10 millimole values, and he was depressed, and he didn't wanted to check glucose more frequently, and he was gaining weight. So we suggested him that you have a CGM device. We put a Libre, we use that. So we were switched to pump after Libre recording, and I'm going to show you he was switched to pump, short-acting insulin with differential basal rate, recommended follow-up. So this was his profile after we switched from his A1c of 7.7, and it achieved 7.1, and this was profile pretty. I mean, this is one of the recordings which you need to do when you're putting the patients on insulin, the carb ratio and sensitivity factor and so on and so forth. But look at the profile of this patient. Peaks and valleys, shall I call. So lots of peaks and valleys in this patient. And look at the profile later on. Pretty straightforward. And we achieved in that particular patient 99% time in range. You want it to be around 70 and above. But if you tweak your insulin dosages and adjustments, you can achieve more than what you are bargained for. So this was one of the success stories. So IDegAsp that was for time in range and not for IDegAsp. But IDegAsp provides similar glycemic control amongst all the trial, lower insulin dose, reduction in nocturnal and overall severe hypoglycemia. Fasting and postprandial glucose is achieved with the flexible dosing. And most of us have got a one large major meal. So if you're using a combination of IDegAsp and insulin, degludec and ASP, the chances of neutralizing that one large meal may be simple. It's a simple identification option and flexibility versus dose and timing of basal bolus. And I'll finish here in time. Thank you very much.
Thank you so much, sir. Excellent explanation of this time in range and A1c matrix. So now I would like to call the chairpersons to please comment on this. Your comments.
First of all, excellent presentation, Professor A.H. Aamir. As always, it's a pleasure to listen to your presentations. Yeah, it's wonderful we have insulins like this which can give peakless coverage for the basal insulin for 24 or even 36 hours. And it works great for patients who have relatively short to mid-range in terms of duration of diabetes. Sometimes the caveats, and that's my question to you as here, caveat we can come across is someone who has a very prolonged duration of diabetes and is not just eating one meal, but rather taking 2 or 3 meals. Were there any group of patients where in this study who were diabetic for, let's say, more than 20 years, and where the fasting we were able to control very well, and one post-meal glucose, good control, but did you come across any issues with other time glucose excursion in the higher range, in those with a longer duration of diabetes?
You're talking about the case, or you're talking generally about
generally in this study?
Yeah.
Yes.
Well, Well, I think the basic recommendation is you start with the basal, but I think in our setup, and as you would agree with me, that we're carried away with the basal insulin. And what we do is over-insulinize the basal insulin and not realizing that the problem may be in the prandial. And as you rightly pointed out, that fine, you're neutralizing one meal, but what about the other meals? And the teaching is that yes, you will neutralize the major meal, but you might require another short-acting for another meal. I still feel that the injection numbers may be reduced if you are using one prandial and one combination which will act for 24, 48 hours. So you rightly pointed out that may be the case. One shot may not be enough, and you might need a second shot of short-acting. I agree.
Thank you.
Dr. Umar Raja, please.
So again, excellent talk by Professor Aamir. I think that concept of time in range, for me, both are important, HbA1c and time in range, and I consider that as a pilot, you look at different dials, and you need as much dials to get as much information. So these are most probably contemporary rather than one or other. Each have got their own benefits, each have got their own pros and their own cons. And on top of that, maybe we need to think about the GVI, so glycemic variability index, because that's another factor as well. And coming back to the data that you have shown about time in range, reducing microvascular complication, that's also derived time in range from DCT study. The third thing is the ARISE study, and pretty much, I mean, our own local data. So I did a small study, 3-month study, which was pretty much similar to the ARISE study. So about 1.2% reduction in HbA1c, but most importantly, about 1 kilogram weight loss. And initially, that was before ARISE study, and I was actually thinking about why with that insulin, you are losing a bit of weight and not gaining weight. And there are some mechanism and reason behind that, but that was pretty much surprising to see the same data that you see in the ARISE study. So again, excellent presentation.
Excellent talk. My question is this, that जैसे आपने बताया कि बेजल बोलस इंसुलिन को कैसे शिफ्ट करेंगे राइजोडेक पे, उसी डोज पे शिफ्ट करेंगे या उसमें कोई चेंज करेंगे?
Right. You're talking about the study itself, the switch over from the basal. So you've got a basal rate there, and you're calculating the basal. So whether you want to switch the basal bolus, which is considered to be the gold standard, but if the patient doesn't want, then you can calculate the total dose, reduce 10%, and start at different timings, 2 timings. You can use IDegAsp even at twice a day, and then see the titrate. I think in all the insulin management, starting is not a big issue. It's the titration which is the big issue, and that's where most of the physicians, most of people who are treating their type 2 diabetes fail, because we don't titrate quick enough, and we don't titrate enough to get the dose what we want to.
Patient is already on premix 50-50. How will we calculate the shifting dose?
Yeah, the first thing which I'll get from 50-50 is your patient is eating too much. That's why you're giving him 50-50. And there's no way on earth that is easy to manage that patient who's eating too much. So I think switching from 50-50 to 70-30 is a daunting challenge, and the best regimen for 50-50, who I believe is the patient who's eating too much. From this forum, I can say, try GLP-1 if it's a type 2 patient. That will be a better option.
Why we are shifting from premix 30 to Rhizodec, same formulation?
Yeah, because the insulin Degludec has got a longer basal action.
Yes.
So the chances of hypo are less. It's a flat response. So obviously, whenever we heard the talk the other day about the hypoglycemia, the chances, one of the determinants or things which pull us back is the chances of hypo. So if you're on a human premix and switching, one of the reason would be that premix will cause a lot of hypos, and that may be reduced by using this.
In my
There are
patients, I
4
have
questions.
observed the weight gain is less as compared to other premixes. In your practice, it is also true. When you shift from premix 30 to Rhizodec, the weight gain is less as compared to.
That's what we have seen. So if you're injecting on a single dose and continuing with the orals, the chances of weight gain would be less. But if your dose is exceeding 0.5 milligram per kg and so on, obviously the weight gain will be.
Thank you.
Okay. So in interest of time, just one question by Dr.
One
Abdul
more
Naqvi,
question,
and then we
please.
finish.
Yes.
Aamir, thank you very much. Quite enjoyed actually. I think one area which is very important, and I see that in practice a lot, is the over-basalization phenomena. And I think we all get carried away, and we know that insulin has a ceiling effect. And I think what is very important really in terms of basal insulin is that we all need to realize this, particularly in type 2 diabetes, whereas you know that the primary defect is really postprandial glucose. So, I mean, do you want to comment on the over-basalization just for the audience, because this is such an important area?
I totally would echo what you've said, and I've just mentioned in Khurshid's comment as well. Over-basalization is one of the problem that we are happy with single dose, and we keep pushing basal, where the problem is in the prandial, and we just don't want a second injection. And I think we probably had to modify our management in terms of whether you want to give a combination. I mean, don't quote me, but I even give single, 70-30 for that matter. At least we neutralize that meal, So I think I totally agree that over-basalization is one issue which we need to deter from. Thank you.
And I gather the rule of thumb is if your basal is over 40 units, think
40.
about prandia.
Yes, correct.
Okay.
Thank you.
Thank you so much. Now we are ending this section and we are proceeding to the next section. For that, I would like to call the Dr. Adnan. Yes, it needs a round of applause.